Hi, I'm Jody Anderson, and this is my NU665 SOAP note presentation, patient presentation. Today, Molly is a 30-year-old gravid-0 presenting with complaints of irregular periods and pain to lower abdomen and lower back radiating into both legs. Her pain starts the week before her menses and then subsides a few days after her bleeding starts. Her menses are heavy and she passes clots. Occasionally, her pain is so severe she must miss work. She is sexually active with her fiance and uses condoms. She reports many years of dyspareunia, which seems to be worsening. She denies history of abdominal PAPs or sexually transmitted infections. Her HPI, she is alert and oriented with appropriate interactions. She is her own reporter and appears reliable. The patient presents to her primary care provider after experiencing lower abdominal pain. She states she has had dyspareunia for many years and has never had an STI. Her past medical history, childhood illnesses are none. Adult illnesses, she's had iron deficiency, anemia. Hospitalizations, none. Past surgical history include wisdom teeth removal and a tonsillectomy. Health maintenance practices, she reports that she feels safe at home, denies being afraid in any relationships. She has no tobacco use, no alcohol use. She regularly is active or exercises, sleeps 7 to 8 hours per night. She has a regular diet, feels like she has positive relationships with family and friends. Coping and stress management, she does meditation or goes walking. She responded no to all questions of the CAGE screening. She does not use illicit drugs. Current medications are a multivitamin and vitamin D. She has no known drug allergies. Her subjective history would include when her last period was, how long her periods generally last, what kinds of things she's done in the past to help with the pain and heavy bleeding during her period, has she had any nausea or vomiting, has she had any diarrhea or constipation, perimenstrual tenesmus, dyschezia, dysuria, hematuria, distension, or early satiety, chest pain, pneumothorax, hemothorax, hemoptysis, scapular or neck pain may be present in women with thoracic endometriosis. So those are things to consider. When was her last pap smear? Does she have any family history of endometriosis, pelvic pain, infertility, hysterectomy, and first or second degree relatives? Has she had any fever or chills, any new abnormal vaginal discharge, unanticipated vaginal bleeding after coitus, any recent hysterosalpingogram or other procedure breaking the uterine barrier, any urinary discomfort or pain with bowel movements? Review of systems, she's a 30-year-old Caucasian female. She denies any distress, denies weakness or fever, denies recent weight gain or weight loss, endorses pain prior to and during menses. Her skin, she denies presence of rash, itching, dryness, or changes in skin color, denies changes in size, shape, or color of moles, acknowledges that freckles increase with sun exposure, denies changes in texture of hair or nails, denies hair loss. Her neck, she denies any recent neck injury, stiffness, goiter, swollen glands, or lumps. Chest, she denies any lumps, pain, discomfort, or nipple discharge. Respiratory, denies shortness of breath, dyspnea on exertion, cough, sputum, wheezing, or pain with inspiration. She has not recently had any chest x-rays. Cardiovascular, she denies any palpitations, chest pain, heart murmurs, shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, or edema to extremities. The gastrointestinal, she denies any difficulty swallowing, nausea or belching, denies any diarrhea or constipation, reports bowel movements daily. Currently, bowel movements are brown and formed. Patient does have pain with defecation during menses, denies any rectal bleeding, black or tarry stools, denies jaundice or gallbladder or liver problems. Her peripheral vascular, denies leg cramps, leg pain or discomfort, varicose veins, edema to calves, legs, or feet. Denies history of DVTs or neuropathy. Urinary, she endorses dysuria and urgency during menses, denies polyuria, hematuria, hesitancy, straining, or flank pain, denies nocturia, denies history of kidney stones, ureterocolic, or incontinence. Genital, she denies any hernias, denies any history of yeast infections, denies vulvar or vaginal pain at this time, denies history of STIs, currently uses condoms, is in a monogamous relationship. She is heterosexual and interested in the male sex and denies concerns about HIV. Musculoskeletal, denies joint or muscle pain, stiffness, arthritis, gout, or limited range of motion to any joints, denies neck or lower backache at this time. Psychiatric depression, endorses intermittent anxiety, self-managed with meditation. Patient is calm and euthmic, denies nervousness, tension, or changes in memory, denies suicidal ideation. Neurologic, she denies any history of head injury, headache, lightheadedness, or dizziness, denies changes in mood, attention, or speech, denies changes in orientation, insight, memory, or judgment, denies vertigo, fainting, or blackouts, denies weakness, paralysis, paresthesia, numbness, tremors, involuntary movements, or seizures. Hematologic, she denies anemia or frequent bruising or bleeding, currently denies any history of previous blood transfusions. Endocrine, denies heat or cold intolerance, excessive sweating, excessive thirst or hunger, polyuria, thyroid trouble, or changes in glove or shoe size. Her objective assessment, generally the patient is alert and oriented, able to communicate needs effectively, calm and cooperative with care. Appears, stated age, appearance is well kept and clean, not malodorous, steady, smooth gait, no apparent sign of distress, has an athletic build with good posture, vital signs, temperature 98.4, blood pressure 118/72, heart rate 84, respiration 16, room air sat 99%. Her skin is warm, color normal for ethnicity, moist palms and axilla, normal skin turgor, nails without clubbing or cyanosis, no jaundice, hair short, thick, no hair loss, negative hair pull test, negative tug test. Her neck has no swollen lymph nodes, trachea midline, neck with good range of motion, thyroid gland is palpable, thorax and lungs. Thorax is symmetric and non-tender with good expansion, lung sounds resonant and clear to auscultation bilaterally, no adventition sounds, breathing even and unlabored. Her breast, axilla, and epitrochlear nodes, axillary lymph nodes consistent and non-tender, epitrochlear lymph nodes consistent and non-tender, cardiovascular, good S1 and S2, no S3, S4, or murmurs. Her abdomen is soft, round, non-distended, non-tender to palpation, no masses or organomegaly, Valsohn's positive for ×4 quadrants, no abdominal brutes or friction rubs, no rebound tenderness, guarding or rigidity, tympanic abdomen, dullness over liver, liver span is 7 centimeters in right midclavicular line. Negative Murphy's sign, no fluid wave or shifting ascites, spleen and kidneys not palpable, tympany to trob space, no costovertebral angle tenderness, bladder not palpable, negative obturatus sign, negative iliopsoas sign, negative Rosvig sign, no pain at McBurney's point, no ventral umbilical or inguinal hernias. Her peripheral vascular, the extremities are symmetrical and warm, no edema or cyanosis, no varicose veins or venous stasis, no swelling to inguinal lymph nodes, calves non-tender to palpation. Genitalia is normal genitalia with no external lesions or eruptions. Rectal, her stool is brown. Rectovaginal exam revealing uterosacral nodules and tenderness within. Pelvic exam, focal pain and tenderness on physical exam with immobile pelvic organs. Musculoskeletal, no joint deformities, full range of motion to all extremities, gait is steady and no weakness. Nervous system, her mental status is alert and oriented, thoughts coherent, able to state the months of the year backwards, calm affect, mood euthemic, cranial nerves 2 through 12 intact within normal limits. Motor system, good muscle bulk and tone, strength in all extremities, 5 out of 5. Gait steady and fluid, no weakness noted. Reflexes on her right biceps and left biceps 2+, right triceps 2+, left triceps 2+, right patella 2+, left patella 2+, right ankle 2+, left ankle 2+. The differential diagnosis include endometriosis. This condition usually presents during teenage years and will include symptoms such as chronic abdominal pain and or pressure, heavy menstrual bleeding, dyspareunia, severe dysmenorrhea, pelvic pain that is dull, sharp, or throbbing, and bowel bladder dysfunction. The plan is a physical examination, a vaginal exam to assess for focal tenderness, nodules in the posterior fornix and adnexal masses, and immobility or lateral placement of the cervix or vaginal mucosa, but a normal vaginal examination does not necessarily exclude disease. Labs would include a transvaginal ultrasound. It's easily accessible and low cost compared to an MRI, and just as efficient at diagnosis of endometriosis with findings such as ovarian cysts, nodules of the rectovaginal septum, and bladder. For definitive diagnosis, laparoscopy or laparotomy is performed to remove tissue, which may be described as red and blue-black lesions or powder burns or chocolate cysts. Pharmacological interventions would be to reduce pain through various methods, including reduction of inflammation, suppressing ovarian hormone production, blocking the action and production of estradiol, and to the reduction of completely eliminating menstruation is the goal of medical therapy. Danacrine, medroxyprogesterone acetate, gestrinone, OC pills, and GnRH agonists have all been found to be equally effective in reducing endometrial-associated pain with OCs and NSAIDs recommended as first-line therapy, and if failure happens with these, starting a 3-month course of GnRH agonists is appropriate. Non-pharmacological interventions would include regular exercise and counseling for pain management strategies. Some dietary interventions have been considered protective, such as eating fruits, green vegetables, and 3 long-chain fatty acids. Education for the patient would be to encourage the patient and partner to discuss their desires for family planning, marriage, career, education, and the impact the disease may have on their daily life, with an assessment of depression in the patient. Referrals, it would be appropriate to refer patient to an expert physician in medical and surgical treatment of endometriosis, especially if patient wants to conceive, fails to respond to first-line therapy, or needs a definitive diagnosis. Follow-up, the patient would follow up in 3 months to discuss incidence, severity, and cyclicity of pain, dysmenorrhea, and dyspareunia, with review of medication, effectiveness, or side effects unless she has other concerns or feels that treatment is not working. The other differential diagnosis is pelvic inflammatory disease, which is defined as acute and subclinical infection in the female genital tract, which may involve any or all of the uterus, fallopian tubes, and ovaries, possibly involving adjacent pelvic organs, resulting in endometritis, salpingitis, oophorytis, peritonitis, perihepatitis, and tubo-ovarian abscess. The plan is to assess the patient's vital signs, since an elevated temperature greater than 38 degrees Celsius or 101 degrees Fahrenheit is indicative of infection. Perform an abdominal exam to assess for guarding, rebound tenderness, and pain with palpation over lower quadrants, and assess for purulent cervical or vaginal discharge, cervical motion tenderness, uterine tenderness, or adnexal tenderness. Labs would be assessing for chlamydia and gonorrhea with NAATs is recommended by the CDC, and also performing a wet mount smear to assess for the presence of white blood cells, check the pH of vaginal secretions, and perform a whiff test. Urine HCG, urinalysis, CBC to show an elevated white blood cell count indicating infection, ESR and C-reactive protein to determine inflammation. Pharmacological interventions include antibiotics, and those that are highly recommended and effective are ceftriaxone 250 milligrams IM single dose plus doxycycline 100 milligrams POBID for 14 days, and the addition of metronidazole 500 milligrams POBID for 14 days if there is a risk of anaerobic organisms present. Patient education, teaching what the patient should include avoidance of sexual intercourse until the course of treatment is completed, using condoms consistently and correctly, vaccination for Hep B and HIV for those that meet the criteria, and offering HIV prophylaxis for those presenting with new STI or PID. Referral is necessary if there is no significant improvement in symptoms after 72 hours of treatment. Then the patient should be sent to the hospital. If surgical emergencies cannot be excluded, the patient is pregnant, or failure to tolerate outpatient therapy, and severe illness with nausea, vomiting, high fever, or patient has a TOA. Follow-up. Patients should follow up with clinician 48 to 72 hours after antibiotic therapy was started, and if there is an appropriate response to treatment, patients should follow up in 1 to 2 weeks. Thank you.